you mentioned that when you working real closely with clients with severe depression can be draining, and I felt very fortunate because even though we did initial orientations, which usually they were designed to last 10 minutes, they usually lasted 30 minutes to an hour. It was the first time somebody actually got to speak about what really bothers them. But inside the group, it was a 2-hour session. Pam and I would get there, we'd set up the group, the clients would come in, we'd do it. It would be a few minutes if the client wanted to talk afterwards, and they went home. But we still had to deal with our own feelings about it. And for me, like Jenny said, I practiced the CBT, and I learned the CBT on myself and practiced it on myself consistently and constantly. And I was joking with Pam earlier. I said, "Get depressed much?" She goes, "Yeah, off and on. Same for me. It's normal blues, but it never turns into depression now. Normal blues. Economy's bad. Life is hard sometimes, but the difference is a client, like Jenny was saying, who has a history of depression without having a set of tools that they can help themselves with. What does it take? Losing a job, losing a mate, losing that kind of thing, and you can go into a spiral of depression real quick. And working with clients like that, I did not take their stuff home with me. I could empathize, but it wasn't my feelings. It was theirs. That proved to be a big help for me.
I want to make sure we have time for our last two presenters. We have one final question.
A question and also an experience. The first question is, how can we define depression?
We use just the DSM criteria when we think about depression, which is those, 5 of 9 symptoms, I think, that are pretty frequent. And so we use that boring old definition, I think, that's generally used in medicine.
Secondly, I'm very grateful to be part of the question today, because I came individually, independently, not to come and learn. I think I succeeded in learning a lot. At least I learned what is CBT today from my own personal interest and my own personal observation. Before one would treat anything at all, the person should know, what am I treating? What is the problem? And then also know what is the problem and what is the cause of the problem. Because at times we treat the effect without attacking the cause. And that's why you have maybe repeat the causes in the future. Most of the time, you don't even need to ask the person, are you depressed? No. By looking at the face, looking at the hair, or physically, one can have some doubt. And then you only to allow the person to confirm whether the doubt you have, is it right, or am I wrong? So, and also I know what is here in page 3, the third page in this paper, and some of the questions you need to ask. If the person didn't express anything, some questions will now reveal the state of mind of the person. To know whether the person is passing through, there are so many types of depression: economic depression, you have a marital depression, have also social depression, economic depression. All these, one will know what about depression, and also to know what techniques am I to use. Like in case of substance abuse depression also, so many people involved in this area. What I do personally is try to know what the cause of the sickness. Because some people take, in Spanish, it said, one going from Guatemala to Guatepeor. One trying to go from so one maybe as an escape, I call it also escapist tendency, trying to escape maybe a circumstance, then by trying to indulge in alcohol. Then also not to know what's really leading to the person. And also to let the person know that the mind is so powerful. Some they say that I can't, but I can't do that. No, I can't, I've tried, I can't. No. Tell the person you can. This is what you have your head. You still can. You only need to make some shifts. And then also try to let the person know the harm he or she is causing, not only to himself but also to the society. If it is in the family, the whole person in the family suffers. And try to make one also to realize that actually what he or she is doing will affect the positive change in the person. But the bottom line also lies in trying to listen to the person, accompany the person the way one can. And also, I love the CBT method because it doesn't involve medicine. It involves therapy, discussion, working with the person, trying to help the person. It will also need a lot of time. It's a challenge. It needs a lot of time. The doctor will give you 10 minutes. For you to really to attend to this, you need more than 1 hour to stay with the person for a first visit. And then people find it difficult to deposit their confidence in someone, to open up, That's why for the first month, there's no truth is coming until eventually when the person has the confidence in you, then the person will now try to take what he or she has, the worries and the anxiety them onto your hands. So also, and also one of the challenges will be the time. Thank you.
Thank you very much. We will need to make this the last one and move to our last. Yeah?
Me?
Yeah.
Okay. I have a question. I have had a number of depressed substance abuse clients. And when I notice that it's likely that they're also depressed, I give them their depression inventory right away. And some people who were previously diagnosed with depression show a high score. Some don't show any score. So not always the assessment, the previous assessment was correct, I believe. And also, most clients, almost any depressed client, has never seen the back depression inventory. So doctors and therapists don't give them back depression inventory. They ask 4 or 5 questions. They give them the diagnosis of major depression. And if it's a psychiatrist, the psychiatrist prescribes medication. That's it. No bad depression inventory, no MMPI, no nothing. No assessment but medication and the diagnosis. Why is it so?
Well, I don't know. I mean, I think I think we've struggled a lot to get good assessment in place, and it hasn't really worked very well to date. But I do like your points. I think you were making some really important points that sometimes it's hard to tell until you do a pretty good assessment whether somebody's going to come out really depressed or not. Sometimes I think we're all wrong, and the assessment tools can be very helpful in that. I appreciate that.
Ideally, I would need 4 or 5 hours to assess one client, just for assessment. Everything. But no one has this time.
Yeah, yeah.
Sometimes I finish it in half an hour. Everything, including the depression, everything.
That's great. We do have some brief depression screeners that can be quite helpful. Did you guys use the PHQ?
We did.
Yeah. You know, the PHQ is a screener, and I think it's in your packets, that is quite brief and can, you know, your point also, nothing's perfect. I mean, I've never found something that I think was perfect, but it does quite a good job of helping us at least know who we want to check out more. So I appreciate your comments. Okay, well, I'll turn it over to our final 2 presenters.
Thank you.
Thank you guys very much.